I'm Dr. Kara Pepper, and today we're going to talk about something that comes up in my clinic all the time with folks struggling with nutrition. It's refeeding syndrome and subsequent hypoglycemia as part of hypermetabolism when people start to eat again. I'm a physician in Atlanta, Georgia. I am a doctor, not your doctor. Please take all of this to your medical team and ask them questions about your specific care. Um, a little history lesson before we dig in. People have been living with feast and famines since the beginning of time, but this syndrome, so-called refeeding syndrome, we kind of look back in the mid-1900s and World War II when prisoners of war and concentration camps were rescued. When they would start to feed these starving folks again, there was a subpopulation of them that would die suddenly for reasons that were unexplained. They would have weakness, confusion, heart arrhythmias, fluid retention, and then die shortly after starting to eat, which we didn't quite understand why that was happening. And about that same time, Ansel Keys, who is quite infamously associated with the misnomer of the BMI, he conducted these experiments where he intentionally starved volunteers and then watched to see what happened. He followed their mood, which became like very depressed. People became obsessed with food, thinking about food all the time. And when he started to refeed them again, they experienced the same symptoms that prisoners of war did. They had edema, they had heart failure, they had neurologic symptoms. So this idea of refeeding got started. And so in the hospitals at that time, they were actually following labs and they started to see these electrolyte shifts, specifically with potassium and magnesium and phosphorus in the labs. And by the time the 1980s rolled around and we were actually feeding people with tubes that went either through your nose down into your stomach or through your abdominal wall into your stomach, or people were getting nutrition by vein, they were seeing the same phenomenon when really malnourished ICU patients were aggressively refed. So it had become well documented by the turn of the millennia, particularly in the oncology and ICU patient population. But in my world, the eating disorder world, we started to see and recognize that this was also happening to folks who were starving. So refeeding syndrome is one of the most life-threatening complications of restrictive eating disorders and something that we work to try to prevent in my field of medicine. And so when we talk about why folks die of eating disorders, and we know that eating disorders are the second most lethal mental health disorder after opiate overdose. The reasons why people die are several, but one of these is refeeding syndrome that can cause electrolyte abnormalities, cardiac arrhythmias, and sudden cardiac death. So we would like to prevent this from happening. This is a long list of other things that can worsen your risk of having refeeding syndrome. You can pause and read, but in short, it is things that cause malnutrition, so GI issues, neurologic problems that keep people from eating, cancer and failure to thrive, food in access to food, particularly in the refugee population. And so you can pause and read this whole list, but there's many other things besides eating disorders associated with this. So this is, for the nerds in the audience, really what we're seeing mechanistically, what happens. In short, people are starving. Their bodies are not getting the fuel that they need. And when we start to feed them, glucose levels, which is a basic building block of energy, glucose increases. And so our body responds in a couple of ways. One is that we release insulin so that we can process the sugar and put it into our cells. And by doing that, it increases sodium and water retention. That's what causes the fluid overload, which can lead to heart failure, cardiac arrhythmias, and problems with a heart squeeze. It can also make people feel short of breath, and you can see it peripherally, like swelling in your fingers and legs. It can also, the release of insulin, cause a shift in phosphorus, potassium, and magnesium, into the cells, which can lead to those electrolyte abnormalities, which also exacerbate the arrhythmias. And it also can make people feel nauseous and cause muscle breakdown and cramping. And then lastly, especially if there's comorbid alcohol use or a reason for thiamine deficiency, it can cause some of the neurologic symptoms. So just by feeding people, it creates this entire cascade of events that can be life-threatening. And so what that looks like kind of from a 10,000 foot view standpoint, basically head to toe symptoms, neurologic stuff. So people can become confused, lethargic, disoriented, and with visual issues and seizures. People can have trouble swallowing because the mechanism of their swallowing is not working well. Heart problems, like I mentioned, the heart's not squeezing well. You can feel short of breath, kidney failure, nausea, vomiting, muscle weakness. All this stuff is bad news. No one wants it. So how do I, as a clinician, anticipate that this may happen for my patients? There is a what they call the Aspen criteria that looks at risk. So if there's a moderate and significant risk, that implies that there's also a low risk. So ideally, we would want our patients to be in the low risk category. But basically, of these 5 criteria, which is the BMI, stay tuned. In a couple of weeks, I'll be talking about the BMI, but that is one of the current criteria. The amount of weight loss, what people are actually eating leading into the assessment, the labs themselves, and co-occurring conditions. So of these 5, 1, 2, 3, 4, 5, you get a point for each. And if you have 2 or more of these criteria, that puts you at moderate risk, or if you have one of the more significant variants of that, it puts you at significant risk. A comment about the BMI, the criteria are low underweight BMIs, either 16 to 18 or less than 16. Absolutely, I have patients who live in, quote, normal or large size bodies who are starving and are at risk. This just happens to be what the Aspen criteria put in their criteria. But people in larger bodies certainly can be starving and at risk for refeeding syndrome. Weight loss specifically, so 5% in a month, or 1 to 2 pounds per week for at least a couple of weeks, or more significant weight loss. Then caloric intake, are people actually able to eat at least 75% of their estimated daily energy needs? So are they eating enough, or are they avoiding entirely? That's a short summary of these 2. And then electrolyte abnormalities, minimally low or significantly low. And then the co-occurring diseases that I mentioned were this list right here. So let's say hypothetically you had, a digestive issue, or you had AIDS, or you had ongoing alcohol use, which puts you at risk for vitamin deficiencies. Maybe that puts you get a point here. You had not been eating, and you had been losing some weight, and particularly if your body size is smaller, that's how these points accumulate. So when I look at a patient and I'm taking a dietary history and listening to other medical problems they have, I'm kind of mentally calculating, do I think this person is low, medium, or high risk for refeeding syndrome? If they're low risk, awesome, that's ideal. If they're moderate risk, that means I may want to consider putting them on some phosphorus in the outpatient setting to prevent refeeding syndrome. And if they're at significant risk, that's when I start talking about it's not safe to feed you in the outpatient setting. I need to put you in a hospital so we can monitor your labs and make sure that you don't develop refeeding syndrome. So the tests that I would be thinking about ordering would be what they call a comprehensive metabolic panel, which looks at kidneys, electrolytes, and liver. And then obviously a magnesium and a phosphorus. The phosphorus is the big one that we follow in refeeding syndrome. And the time frame in which this happens is usually in the first 5 days, where people start to eat again. My amazing colleagues who are dietitians are excellent at kind of calculating the rate at which we increase people's intake. We don't want to start people on a full diet the very first day. We want to increase it over time, and they make those recommendations. But as they are increasing my patients' feeds, I'm watching these labs, particularly in the first 2 weeks. And then I wanted to talk a little bit about the continuous glucose monitoring. I'll show you what some of those curves look like. But it is a way for me to be able to tell, in addition to the refeeding risk, are people dropping their sugars, which makes all of the arrhythmia risk a lot worse. So let's take a look at that. So a continuous glucose monitor, you may have seen, is like a little button that, actually I've got one on today, that people may wear on their skin that follows their sugars 24 hours a day. I have a separate video that talks about how to apply these, and you can look at that in the channel. But this would be a normal continuous glucose monitor curve. So you can see this is 6 a.m. to 6 a.m. the next day. So this is someone who wakes up and eats a breakfast, their sugars go up. This may be a little higher than we would anticipate, but not terribly. This is someone, they eat lunch and then insulin gets released and their sugars come back down. Here's dinner. And then over time, over overnight, our sugars kind of regulate to our baseline. So this is what I would expect to see in looking at a glucose curve. This is a patient of mine with consent. They allow me to use their curves. You can see that they are not eating and their sugars are running pretty low continuously throughout the day. You don't see those spikes where they'd eaten. In fact, you see one from the day before where they had actually eaten something and their body reacted really strongly, secreted that insulin, and the glucose just absolutely plummeted to a critical kind of life-threatening place. That was not a great day. So this would be someone who's running way too low because they are undernourished and don't have the reserve to keep their glucose levels up. As we started to feed them, they would have these spikes. You could see that they would eat. This is like just after midnight. They'd had a low overnight. The alarm on the machine had woken them up. So they got up and ate something, but then their sugars came right back down. And a normal sugar fasting would be like 80 to 100. So this is right at 70. That's where the green line ends. And so 70 is still, lower than we would anticipate. But you can see here's breakfast, here's their morning snack, and lunch. Here's another kind of late lunch, and then a snack, and then here's dinner. So when they have the bigger meals, their body is still reacting strongly by secreting insulin, and their sugars are crashing. So they're still having some, but certainly not like what we saw before. And then as they continue to nourish their body and their insulin, their glucose reserves, their glucagon was able to behave in a more appropriate way, their low sugars became less and less. So what I would suggest about all of this, and the reason I'm recording this for patients in the future, is to say there are ways that we can anticipate your risk, not 100% of the time, but we can certainly look and see. And so if your doctor is worried that you're going to either one, have low sugars, or two, be at risk for refeeding syndrome, there are things that we can do to monitor that. And also try to prevent refeeding syndrome with the prophylactic phosphorus supplement. Like I mentioned, you absolutely need labs. And one of my major frustrations with the lack of understanding of eating disorders in our society is that if I think someone's at high risk for refeeding syndrome and I don't feel safe managing them in the outpatient setting, they need to be monitored. Unfortunately, many people's labs look fine when they show up in the hospital because their body has adapted to starvation over time. And so you may show up in an emergency room or an urgent care situation. They say, great news, your labs look great. It's not that day that's the problem. It's once you start eating in those first, particularly 5 days that that refeeding syndrome starts. So that's when you need to make sure you're working with your outpatient team or your inpatient team to make sure those labs are being followed. Again, I'm Kara Pepper. If you have any questions for me, want to sign up for my email list for future educational events, you can find me at this QR code, and that's my website for appointments. Happy to answer any questions or accept suggestions for topics. I hope you have a great day.